everyone. I'm so excited to have everyone here. Before we begin, I'd like to acknowledge our countries. The University of Melbourne acknowledges the traditional owners of the unceded land on which we work, learn, and live, the Wurundjeri and Boonwurrung people. We pay respect to elders past, present, and future, and acknowledge the importance of Indigenous knowledge in the Academy. We also acknowledge that sovereignty was never ceded, and we also extend this respect to all traditional owners of the lands from which our participants are joining us today. So a quick housekeeping. For question time at the end of the seminar, please submit questions through the Zoom Q&A function at the end, and I'll be monitoring those. So my name is Debbie Passy. I'm a research fellow at the Center for Digital Transformation of Health at the University of Melbourne. Our center is on a mission to catalyze an informatics-powered learning healthcare system where patients and professionals thrive. We aim to make the right informatics skills and expertise available to support and grow translational research ecosystems that focus on digital transformation. We do this through education and workforce capacity building and through our Validitron research platform. We have methodological strengths in digital health problem validation, co-design and consumer involvement, implementation science, simulation-based research into human factors, and program logic-based evaluation. So we're delighted to be hosting two speakers today from the Adult and Child Center for Outcomes Research and Delivery Science, or the Accord Center at the University of Colorado School of Medicine. This seminar is to kick off our collaboration between our two centers at the University of Colorado and our center at the University of Melbourne. So with that, I will quickly introduce our presenters and then we can move on. So our Professor Russ Glasgow, he is a research professor of family medicine at the University of Colorado. Professor Glasgow is one of the developers of the RE-AIM, PRISM, and dynamic sustainability frameworks. He focuses on designing and evaluating pragmatic, cost-effective, equitable, multi-level prevention and illness management programs with a particular focus on facilitating accessibility and appropriate use of dissemination implementation frameworks and resources such as the RE-AIM. Our other presenter is Associate Professor Mónica Pérez Jolles. She is an associate professor in the CU Department of Pediatrics and also part of the Accord Center. Mónica's work draws from complex systems and implementation science methods and frameworks such as EPIS and the PRISM RE-AIM to align interventions to local contexts and from collaborative engagement approaches such as implementation and process service mapping, prioritization exercises, and co-creation workshops. Mónica has applied the concepts of core functions and forms to implementing multi-level interventions with fidelity to function and contextually tailored strategies. Her contributions to the field are based on over a decade of experience as a health services and implementation scientist, working in partnership with federally qualified health center systems, community partners, healthcare professionals, and researchers to close the gap through team-based science. So without further ado, I will hand it to Mónica and Russ.
Thank you, Debbie. We appreciate the invitation, and we have quite a lot of material to share with all of you. And then we're gonna leave ideally 10 minutes for questions and answers and have a very lively conversation. So let me move us to the next slide. Again, we wanted to share a little bit of background from Colorado. Again, thank you for having us and for having this kickoff of this wonderful collaboration between our centers. No conflicts to report, and we wanted to acknowledge that this is a team effort, what we're presenting here, and we have an amazing group of colleagues that are mentioned, cited, and that contributed to the knowledge that we and our efforts, research efforts. All right. Yes. What are the goals for our hour together, or what's left of the hour? Number one, we wanted to define what do we mean by implementation science. Some of you may be familiar, but some of you may not. So very briefly, again, this is a short session. We're going to go over what it means, what we mean by implementation science, And then we're going to focus on a PRISM model and new applications of this model in implementation science, as well as RE-AIM. Of course, we have an amazing colleague and mentor, Russ, here to guide us, and new applications or newer applications of the RE-AIM framework. And again, we are going to allow time for questions and answers. We wanted to start, and we're going to retake it at the end, with some take-home points that I hope you find helpful for all of you. If you're a researcher, a practitioner, a clinician scientist, but a few pointers. Number one, context will impact your intervention, your solution, mechanism of change. How you want to bring about change is going to be influenced and impacted by context. And as we know, context can change, evolve, and rapidly. Our second take-home point is that the frameworks and models offered from this field, from implementation science, can really help you design and deliver your solutions to preserve the mechanism of change that you want to make sure is being implemented with fidelity, but also through tailored activities. So the delivery can really resonate with those characteristics of those contexts, and it becomes sustainable. Point number three, well, this means that we need really a very active and multi-level partner engagement. And we're going to touch on that very briefly to plan for the delivery of your solutions so they are feasible, they're acceptable, they are delivered with fidelity, and of course, sustainable. We need to adapt, as in life. We need to adapt, and adapt. So that is a key point in terms of implementing, especially multi-level interventions in rapidly evolving dynamic environments. And the last one, what we're sharing today, PRISM, RE-AIM framework, as well as concepts of functions and forms, are just one approach to addressing issues of implementation. And by no means we mean that this is the approach. There are just other approaches that we want to acknowledge. Okay. So number one, our first goal, what is implementation science? There are many ways to define it. This one, we really like it. It's relatively simple, but at the same time, very insightful. So think of this field, relatively new, as the study of methods to increase the adoption and integration of your solutions, evidence-based practices, into routine healthcare, for example, or they are embedded in healthcare settings. And by evidence-based practices, you can see on the slide, it could be policies, it could be products, concrete products, such as a digital intervention, mHealth, an app, or procedures or actual medications, for example. And this takes us in the field of implementation science to a key area, and is context. I already mentioned in our take-home points the importance of context. And in this field, as probably in your field as well, understanding and being really responsive to those local environments where you are going to deliver your solutions is critical. And that means a couple of things. That means, number one, that we can consider context-based implementation. Oh, that should say implementation frameworks. We want it to be consistent. We're going to focus on implementation or as much as dissemination of evidence. But context-based frameworks that allow us to better understand those contexts, the characteristics of those contexts. And again, we can't do it alone. This really needs to be a team-based effort, team-based science with active participation from patients, community leaders, clinics, healthcare providers, and healthcare systems, leadership, policymakers. As you can see there, key characteristics of this field of implementation science, as we all often call it IS. We're just going to highlight a few, and we're happy to share the slides, Debbie. If that's of interest, we'll share the slides. But notice context is critical. We really strive for aligning the design and implementation of your solutions to the characteristics of those environments, local context. we acknowledge complexity, and there are multiple factors in that environment that are important, and also the problems contributing to those problems. We also talk about representativeness. I have issues always pronouncing that, and reach as a key aspect of our practical goals in implementation science. So you have your clinical outcomes, increase healthy living, for example. But for implementation is, did you reach the communities that you wanted to reach? That's an example of key outcomes and practical implementation goals and outcomes. And we strive for being pragmatic and practical. We strive, we not always succeed, but we strive for that, for being quite a practical field. And now I'm gonna pass it to my colleague, Russ.
Thank you, Mónica. Can you hear me okay? By the way, Mónica, I just realized we had the word you stumbled over. Part of it is we had a typo on that. That should be representativeness rather than representatives. Briefly, I'm just going to say a few words about the model that we're using now, which is a whole mouthful or a sentence. Our practical, robust implementation and sustainability model, or PRISM. A bit grandiose title, admittedly. The word context, you're going to get probably sick of us hearing this, but we think it is so central to success. And I want to reiterate that it is multi-level and dynamic. And also, context is much more than setting. It's not just the place, but it also has to do with history, with culture, with relationships among the different parties there. It has been widely used as a number of different types of frameworks or approaches I won't go into, but an important point I'd like to stress in bold there is that PRISM includes RE-AIM. It's an expansion of the earlier RE-AIM model that started about 10 years before and to address these important contextual issues. Next slide. Okay, so here is a one version of the figure. You'll see another one later that we're working on sharing about PRISM, and a few key points about it. First of all, the big boxes that you see there, we start with context, and I'll say just a word about the key contextual factors that can be summarized as 4 issues. And then to the intervention, which can be a policy program, as Mónica talked with you about, the implementation strategies or the how that policy is delivered, and then the RE-AIM outcomes. Now, the important part of this is that there needs to be a fit or an alignment among all the top 3 things. We had trouble showing that graphically, but for things to work, these things need to be aligned. So it's not just, no matter how great your intervention is, if it doesn't fit the context, if you don't have the appropriate implementation strategy, you're unlikely to get the RE-AIM outcomes at the bottom. Very quickly, if we go to the what's in red there, the top left, the 4 key factors we call domains in PRISM is this notion from multiple participants, those who support and fund it, those who deliver it, those who receive it, is the perspectives on the intervention. And I want to stress that it's not necessarily in PRISM like objective characteristics of the intervention or the innovation, but it's the perspectives that people have. Going down the bottom left, the multi-level partner characteristics. PRISM is very multi-level. So again, we want to talk about all of these different levels, the characteristics of people from the recipients or patients all the way up to the champions and supporters. External environment is critically important and includes a number of structural issues, including reimbursement, guidelines, laws, incentives, those sort of things. And then finally, the implementation sustainability infrastructure is one thing that's relatively unique, I think, about PRISM compared to others. It has to do not only with resources to support a program, but also processes that you may have available. Is there a structure like a QI structure or audit and feedback? Is there good leadership or priorities? Next slide. Okay, thank you. very quickly, we have done an analysis. You can see at the bottom, the first publication in PRISM was 2008. It took it a while to take off, quite honestly, but there's been a lot of work on it. This review was done in, I think it was published in 2022, but had work just through 2021, led by our colleague, Borsica Rabin, who has done a huge amount of work and great collaborator for us. Next slide. In one slide, just quickly, some of the key findings of this complex report is we ended up with 180 articles after doing the usual exclusion process there. And in those, like always happens, the model was used with varying degrees of completeness, that sort of thing. But most studies reported on half or more of those 4 PRISM domains I showed you. The most frequently reported ones were these perspectives on the intervention and then this implementation sustainability infrastructure. At that time, the vast majority were qualitative methods. Since then, we have been working hard to create some more quantitative things. Among the RE-AIM outcomes there, implementation and maintenance, the latter, to our surprise, were the most frequently reported ones. And as you can see in the figure, it was used, again, we were pleased to see across planning, implementation, and sustainment phases. Next slide. I think it's back to you, Mónica.
Thank you, Russ. We're going to go back and forth sharing different aspects. Thank you. So we're very enthusiastic to share a concrete tool, and we want to emphasize the importance of having cycles of learning and using PRISM in a repetitive, iterative way. And one tool that we wanted to share briefly is the iPrism web tool. It's an excellent free online, I will give you details, where teams can go and answer some questions guided by PRISM in this case. And then you will, among other things, you answer some questions alone or with your team as an exercise. But one of the very interesting things is that provides you with a scoring sheet that you see here. On the right, on blue, there are the PRISM scores. Teams answer one question in each category, and it gives you these very interesting maps. And on the left, questions related to RE-AIM, the outcomes, reach, maintenance. And you can see where you are with your team. You don't have to have a complete full circle. It's perfectly fine if you are emphasizing or focusing on some areas. But it's a tool that is available if you are interested to use with your teams. And this is the landing page. Please scan, or you can use, yes, the scan is there, the QR code, where we can offer other tools on how to use PRISM with teams using our iPrism tool. And back to you, Russ.
To me? Yeah.
Yes.
Just a second, if you could quickly go back, Mónica, to the last slide. The QR code on this goes to this document or guide. It doesn't actually go to the iterative PRISM that we call. Later on, we're going to show you that tool. If you want to Google it, it's just called prismtool.org. You'll find it. But if you could help us out, it is publicly available, but it'll ask you for the name of your program. If you want to try it, if you could put test as your name of your program so it doesn't get mixed up with actual ones. We, of course, encourage your real use of it in your programs too, but that would help if you would. Okay, let's go back to my next slide now. I'm going to talk a little bit about RE-AIM very quickly. Half of my career in 5 minutes or less, maybe 3 minutes, but how RE-AIM evolved and turned into PRISM eventually. RE-AIM started, 26 years ago now in 1999, before we had a field formally called implementation science. And from the beginning, though, we focused on overall population health issues. the purpose of it there. And if you can go to the next slide, that does show our website. I'll come back to that. That QR code goes to our RE-AIM website. Okay, so it was intended all along to focus on the second bullet point there as an attempt to balance internal and external validity and had strong emphasis on representativeness and equity. It was somewhat in response to what I saw my colleagues at that point in time to almost a exclusive focus on internal validity and experimental control and pretty much ignoring external validity that we thought had a lot of unintended downstream consequences. From its outset, RE-AIM has been multi-level and has components, or what we call dimensions, at the individual level and at the multi-level setting level. That's really important. And the notion about RE-AIM is the ultimate population impact depends on all of the elements, not just what we usually call effectiveness among participants, not just reach, but all of these factors combined. Next slide. Okay, I think many of you have been told, may have at least heard of RE-AIM, if not used it. I don't have time to go over the REAI things there. Many of you know them. They're in the left-hand side, but I would like to take just a quick second to explain the level called implementation there. That's the reason this is the dimension of RE-AIM that's evolved the most over the years there. And by the way, these are pragmatic definitions. If you want to use it to talk with community or clinical partners, there's many, more technical jargony definitions and surveys and things that you can look at. But basically, I want to talk about implementation for a second. It consists of three important things. One of them is consistency of delivery of your program. That was always there, or fidelity, many people talk about. The next points there on looking at adaptations and cost have been added, but we felt those were just critically important and need to be part of the overall notion of implementation. Another time when Mónica comes to visit you, that works out. She'll talk a lot about adaptations. But let's go to the next slide, given our time. Okay, there have been a number of misconceptions, as with any framework or notion there. One of those was that for a long time, people felt RE-AIM and PRISM can only be used for evaluation. That's incorrect. There's at least 50 articles showing that's not there. For interesting reasons, some people think that its approach is either entirely quantitative or entirely qualitative. That's not true either. We now have a lot of examples of both. Third, and in that article I cited before down there, we don't insist or say you have to use all dimensions, either of PRISM or RE-AIM. We do strongly recommend that you think about each of the dimensions or domains and then use the ones in collaboration with your team members and things that are most relevant and most important to you there. And then the other one, which wasn't really true even originally, but certainly not now, many people feel they can't use PRISM because it doesn't address context. But I still don't understand that one, but we'll move on from that. Next slide. Okay. So why has PRISM, and some of this is in its evolution, done there? We intend, and this is a work in progress, I want to be really straightforward about that, to facilitate transparency and translation of research into practice and policy. I mentioned before its strong focus on representativeness and equity and multi-level things. So I think we'll go to the next slide. Save a little time. Okay, this is a website, another resource here that has many of the things that you've seen there. I will just note that in the top right-hand side, there's a new book. I'm not sure if your group has had contact with Pers Nielsen or not from Sweden, but there's a book I'd highly recommend, came out last year by him. And there are a couple different chapters on PRISM and RE-AIM. both conceptual basis and how they've been used. And also it does a really nice job of other figures. Most of you know, as Mónica says, it's only one approach, but I'd recommend that book if you want to dig in a little bit more, plus our website. I don't know if I have one more, Mónica, or if it's back to you. Let's see. Next one.
Oh,
Let's
you
see.
have a very important one next.
Oh, I do.
It's
Oh, you're right.
our
I do.
mantra.
How could I forget that? This is one of those things about being virtual, because I would love to do this with you as a group. And one of our take home, if we could do this as a live audience, I want to stress, if nothing else, you take home from this, PRISM includes RE-AIM. They're not different frameworks. They're not competing frameworks. Okay. PRISM is the contextually expanded RE-AIM. So it built on RE-AIM, but it does include RE-AIM. So if I were there, I would say, now repeat after me. PRISM includes RE-AIM. And with that, Mónica, I think it is your turn next.
Thank you, Russ. Yes, we actually have done it in person when we repeat. So Russ is pretty serious about that. All right. So far we have shared with all of you what we mean by implementation science very briefly. We have given you an overview of PRISM, new applications, RE-AIM, and misconceptions. Now let's shift a little bit. We wanted to share our relatively recent work in our lab, and it has to do with equity and applications of PRISM RE-AIM in terms of health equity. And let me share a little bit of how can PRISM, this is not the only one, the only framework, there are others, but how can PRISM help address health equity in the work you do, either as a researcher, practitioner, community liaison. So there are several reasons. I wanted to highlight a few. One is the focus on issues of who am I reaching? And is that group of patients, for example, or clinicians or hospitals representative of the individuals or patients that can benefit the most with this solution, with this policy, with this practice, with this app, health app? So those are issues that are addressed in our contextual assessment guided by PRISM, for example, but as well as with the outcomes of RE-AIM, especially REACH. So this is a key area where we can make sure we are not leaving any group behind. In my work, I work with under-resourced healthcare systems, and they are quite often, they don't have the capacity and resources to innovate or sustain evidence-based practices as more resource, let's say, academic settings. So that could be an issue, and it is an issue for me in terms of reach. How can we close that gap in terms of addressing health equity? Another reason is PRISM addresses, and in general our field, issues of systems. You saw that in the previous graph, and as Russ mentioned it, context is not just settings, but it's history, systemic inequities that are linked to history, economy, distribution of resources, and unintended consequences. So that's another area where we can use PRISM to understand environments and use that information to inform the design, testing, evaluation, and implementation of solutions. Another one that I really wanted to emphasize is that it has a focus on the steps and outcomes needed for population impact and for parity or equitable impact across clinics or patients or communities. And also methods and tools, and we're gonna share with you a few in this hour, but again, we will continue with these events. We have methods and tools. We strive for them being pragmatic to integrate with other frameworks, and that could include health equity frameworks. We acknowledge that the field of health disparities and health equity has been happening for decades. We did not recreate the wheel, and we acknowledge that, and we incorporate and have some humility on experts in those fields. and we incorporate that to the implementation, delivery, and sustainment of solutions. So key points that I wanted to share with you on how you can think of PRISM in terms of equity. A couple of other 2 points on equity. This is work in our lab with Russ, Meredith Ford, Spiro Manson in 2023. It's about thinking, remember the model that Russ mentioned, we're expanding it, and you can see on each of the left and right side, when we think of environment, we need to include many perspectives represented so we can really capture the nuances and what it means external environment, what it means implementation and infrastructure resources. We need to, of course, address context, but you can see areas in terms of, for example, RE-AIM and intended consequences. In the middle, when we design and implement solutions, we need to include our partners during the planning early on to make sure that their visions, their history, their values are incorporated in this process. If you're interested, we encourage you to take a look at this paper. It has concrete applications. In our publications, we always try to make a point, share evidence, but immediately go to an applied example with our research or our colleagues. Another example or key point on equity that we wanted to share with you in a very recent, just last year publication that I led with Meredith Ford and Russ, Glasgow and Russ, sorry, I'm operating the part with Russ, is RE-AIM Equity Outcomes Cascade. And our paper has more details. But this is our best effort to think of our cascade in terms of RE-AIM, that in different order, because RE-AIM, I have learned from Ross, has a very nice acronym, but it doesn't mean always that reach is the first outcome that you're evaluating. It could be adoption. Are you adopting these new evidence-based practices? Have you implemented? Who did you reach? Was it effective? And did you sustain it? An individual and context level maintenance. So we know that we have these outcomes, but we wanted to emphasize that there are key points here by this cascade where we could be mindful of potential and intended consequences or areas that we can keep an eye on to make sure we are achieving parity and equity. For example, during REACH, we can look at using evidence-based resources and strategies to increase our reach, make data-based adaptations. When we're looking at implementation, make implementation simple, low cost, and burden to those implementing it and provide support. Reaches multiple and diverse promotion channels and increase access to increase reach. Effectiveness, what I just mentioned, using data integration, electronic healthcare records, and also database adaptations. So again, key areas for you to consider as you are looking at this, at RE-AIM as implementation outcomes, and to keep in mind to minimize drop-offs and inequities at each of the steps, and knowing that they impact each other. You might need to, after maintenance, you may need to adapt and look at adoption again. So don't think that this is linear. This is really a cycle, and we constantly emphasize the repetitive and iterative approach to PRISM and RE-AIM. All right.
Mónica, could you stay on that? I think I'm next.
Yeah, a little bit more.
That one for just a second. This is one of the many figures we're still working on, and we're not totally happy with it. I don't know if it visually conveys, but this notion of the cascade is what we're trying to show. If you can envision each of these steps being like a waterfall or whatever, and that there's a drop off at each step, and that you lose people, and often the people that you lose are not similar. You know, there are differences there. And the idea is that it reverberates throughout that. So by the time you lose settings at the top that maybe are the low resource settings, serving people that need it the most, right? You see who gets the, full fidelity implementation, you lose more people, et cetera there. So anyway, Mónica did a nice job of explaining it, but if you have ideas for a better visual, help us here to try and get across this concept. Okay, now I'm going to talk quickly about...
Yes, and I just wanted to thank you, Ross. Yes, so the idea is that you might start with a higher number of clinics, partners, patients. But as you experience these drop-offs, you might end up with fewer. They might not be representative anymore. Yes, that's a great point. Thank you.
Okay, I'm going to very quickly talk about being quicker, about the need for speed, we call it. Starting about 5 years ago, maybe a little bit more, we started with RE-AIM. It wasn't all PRISM then, but we realized that both our frameworks and others, have been used quite a bit in the field, but they've been almost always used for planning during the planning phase, or later on with RE-AIM at the end to evaluate something after it was over, but hardly ever iteratively or in between. And we felt that was just a real loss. And also we realized that implementation science as a whole, we're guilty of it too, didn't move anywhere nearly as quickly as our partners need or like to be a learning health system or a partner with them, that we were just way, way too slow. A lot of historical reasons for that. So then we thought to take on the audacious challenge to see if in fact we could use, it was first RE-AIM for a couple of years, and then we expanded to PRISM, use this iteratively to guide adaptations as we went along. Next slide. So how do you use iterative RE-AIM and PRISM? There are 4 steps here. We can do this like in person as a group exercise. You can do it over Zoom virtually. And most recently, you can do it in terms of this web-based tool that we've been talking about. But basically, I won't just read all the words here, but it involves deciding on your team who needs to be there, number one, and then answering a brief set of standardized questions about both the importance and progress that you're making, because it's used iteratively. And then as a team, as a group, reviewing and discussing those scores, especially where you agree and don't agree, and then focusing on priorities coming up for the next period of time, again, focused on using both the RE-AIM conceptual model and your data that you have on progress. Next slide. Okay, this is a little out of sequence, but I'll just say, and we can come back to it in cost, this is another big thing that I feel is critically important and underutilized, just starting to be recognized the last few days. But no matter how wonderful, how cost-effective our intervention is, how much population we reach, if you take it out to a new setting, you want to adopt that, I can almost guarantee that one of the first or the key questions, and if it isn't stated, it's implicit, they want to ask is, what will it cost me in my setting to do this program or this intervention? There's been a lot of things to come up here, but I'm just going to leave that as a teaser now that we want to come back from, but there's a series of articles, one of them is there, about showing the importance of integrating economics into implementation science. I think it's back to you, Mónica.
I just wanted to add that in terms of cost, there's also a lot of interest on what will it cost to implement the program. So there's cost analysis, as you may know, as part of an intervention. How much does it cost this diabetes program? But here is also how many hours of training. What resources did it take you to train these coaches, for example? So it's a focus on the cost of implementing the program, of Jolles strategies. And I also, since we're a little bit ahead of time, we're doing great on time, Russ. We are also in a new project called R2P2, funded by the university. We are pilot testing and developing a costing tool, a tool to track how much does it cost me to partner, to have an active collaboration, for example, and the resources that I need to bring partners, patients, community members, to be part of this project, to this research. So that's another area of cost in terms of the engagement in research. So a lot of new directions that are of a lot of interest to funders, researchers, and even, of course, managers and practitioners. There's one more that is also important. Wait. No, this is still you.
Yeah.
You have 2 more.
It is. I just saw that. Yeah, sorry. Again, you'll see at the end or maybe during discussion, we have another slide about our resources, a different website where you can find these tools as well as some others that Mónica has led that we haven't had a chance to talk about yet. But we'll show you that website. We're just going to wrap up here, a couple more slides, and then have questions. But I want to circle back to where we're at. Again, context is so critically important. We're broken records on that. And it especially changes. And I like in a paper by David Chambers, he led called Dynamic Sustainability Framework. One of my favorite quotes is essentially a paradox. And the notion is in order to sustain, you need to change. And why is because you have to adapt to contextual changes if you're gonna maintain your program and its effectiveness there. We feel that a framework or a model can help. We could have a fun discussion of sometimes, and I actually do believe that sometimes a really good logic model may do as well as a more formal theory or framework. Not everybody agrees with that. It's a fun discussion, but I always recommend starting with the logic model. Okay, working there, and then that can help you. Again, Mónica will work with you, and she's there. We have a whole nother talk on selecting theories, models, and frameworks, and of course, a tool for that too. I think the other things are there. I just want to end at the bottom line with the recognition there that all of these things are work in progress. They are one approach to doing things. There are others, and we'd be glad if we have time to talk about maybe some of the pros and cons or situations were different, but we do want to recognize this, that it's there, particularly doing this in a way that reaches more people, that's more accessible to real people other than us academic wonks. So is there one more slide or is this? Okay. And yeah, again, this sums up right here. I think to end with, all models and methods, certainly including PRISM, are wrong, but sometimes they can be useful if we're helpful. And this notion about complexity science, which Mónica exemplifies so well and has built her career around addressing complexity science. But we want to simplify things to make them more accessible, but not oversimplify them. And particularly this notion of unintended consequences is so critical and we feel has been underemphasized. And is that it now, Mónica, or not?
Thank you. We still have a few minutes. I just wanted to highlight before we go to questions, since we have a few minutes, our website. We have the scan, the QR code, but we have a wide array of resources for you, readings, pragmatic tools. Feel free to look at our resources. We encourage you to, as the part of this collaboration, to take a look at what we can offer. Suggestions are always welcome, but we wanted to acknowledge, yes, the resources and services that we provide at a course as part of the University of Colorado School of Medicine. Consultations, interactive tools, readings, recordings, and presentations. Consultations are focused on faculty on campus, but we can consider also consultations that are outside the university on an ongoing basis. It's a little bit limited, but we provide consultations.
I will also note, Mónica didn't call out, but a couple of the new things under the resources there, which has a lot of both static, traditional resources and FAQs, but also a couple of neat tools. We have several interactive tools, but two of those are one, a neat tool, sorry, stuttering here, on functions and forms and how to operationalize that and do that with a lot of examples that Mónica's led. And then secondly, one that she and I have collaborated with others on co-creation, kind of some methods and again, some guidelines for that are embedded there. So.
Thank you, Russ. We are having a comment in the chat that this QR code is not working. So we will, pardon, if that's the case, we will make sure when we share the slides to, I did check on all the QR codes, but I didn't check on this one. We'll check to make sure it's working for folks.
try and check the small, or whatever you call it, the mini URL at the top. Somebody might want to try that. Hopefully that one will work, but our apologies. We will check this. I think I know why, but
Yeah,
obviously we
it is true.
didn't
Yeah.
double check enough.
Thank you. I just tried it and it has been disabled for some reason. So again, our apologies. These seem to be new. But yes, we also have this link here that hopefully you can follow and it work. Thank you for letting us know. We appreciate that.
Thank you so much. That was, I mean, I was clapping along, you couldn't hear, but and I was repeating along that PRISM is RE-AIM. If so everyone in the audience, if you could pop your questions into the Q&A, if you have questions that you want to ask. And I figured while people are thinking of their questions, I wrote down a few ideas. So one of the things I wanted to ask about, and you kind of touched on it a little bit, is how you could use the PRISM RE-AIM in an iterative fashion. And oh yeah, I'll talk to this one as well. But for this question, I was wondering, could you speak to, so you could use RE-AIM and PRISM in an iterative fashion, and I was just wondering, because I think a lot of people are wondering how we could apply this to a learning health system approach. It seems pretty obvious, but I was wondering if there was any thoughts you had on that.
Want me to start that, Mónica? One, and then
Yes, I have my idea. I'll follow up.
Yeah. If you can quickly do that, I don't know if you can see your slide numbers, but I note that on slide 86, we do have one answer to that, not the only one, but about iterative PRISM. Again, we talked about, we didn't have time to talk about here, but it is a tool that we've developed to do this. You can also do it in person over time as well. But we've tried to make it a standardized, you answer a set of about 20 questions having to cover both PRISM and RE-AIM issues, and then you get immediate feedback. Mónica showed you a little bit of that, but this is a standardized way, and it really works best if it's done with the team. And to be most efficient, you can do it. It takes about 10 or 12 minutes to answer the questions as an individual. But the key part of it is if you do it asynchronously, each of you with the same team link, then you can get feedback on everybody and look at, you can see the congruence of the perspectives that people have there. And then we do have some guidance on the tool as well as on the website about facilitating discussions, using that to generate adaptations or strategies that you then have the team rate on both their estimated, again, it's subjective, but it's an estimated feasibility to do in that setting and its estimated impact. And then from that to further specify a set of factors. So that's quickly just how this program works. Mónica's showing you some pages, screen shares. That last one is where they're prioritizing things there. But Mónica, why don't you add what you want, see if Debbie wants to follow up in case I missed her question, and then we'll see what else you'd like to talk about.
Yeah, I just wanted to add the fact that learning healthcare systems are learning from their own data. So using something like iPrism at a certain point with key players in the learning healthcare system, collecting data, bringing back data and learning, and maybe doing the exercise again on an ongoing basis, and identifying changes in the environment, changes in the feasibility. Perhaps it was low, but now it's high. So I think this tool can help the systems themselves incorporate data and learn from data over time as well. So that's another point that I wanted to make sure I wanted to share. And yeah, if Debbie, you want to add something?
No, it's great. And we have a ton of questions in the Q&A, so I may follow up with you guys later with the learning healthcare system. One of the questions, and it's something I've encountered a lot about whether to use PRISM or the CFR, so the Consolidated Framework for Implementation Research. you know, because both of them are kind of contextual frameworks. And I've actually encountered projects where people are using RE-AIM and CIFAR. And I'm always advocating why just use the PRISM if you're going to use the RE-AIM. But I don't know if you had a comment about the use of PRISM versus CIFAR and choosing one or the other.
Do you want to go first, Mónica, on that one? Or you
I'm
want me
going to
to?
leave the developer one to start. Please go ahead, Russ, and then I can share my take.
Okay, if you can, I'm trying to scroll. We have a slide, Mónica, somewhere on Borsica's website, Theories, Models, and Frameworks website
Yes,
that
let
we
me
should
find it.
look at
Yes.
while I'm talking and running off at the mouth. I think this is a key issue. And first of all, Debbie, a lot of people do that. And in general, we encourage people to thoughtfully combine frameworks, usually no more than two. Otherwise, it gets mind-boggling. And particularly, at least in the US, you'll never get funded if you try and do three or more. It just blows people's minds. But I think it can be helpful to do that. For a number of years, or when we just had RE-AIM, people often would use some other, and CIFAR was the most prominent one, kind of mid-years. Early on, it was Diffusion of Innovation, the granddaddy, you know, of them all. Then they use that, and they'd use the RE-AIM for the outcomes. Now, it's a bit more nuanced because we've added PRISM, so we do have the contextual factors there and the outcomes. And then, as I'm sure you and others know, CIFAR has also evolved in a neat way, and CIFAR 2.0 now does also include, it's listed as an appendix, but they have their outcomes, which are very similar but slightly different than RE-AIM. I think the main differences are that RE-AIM is a little simpler, has a somewhat fewer set of factors. That's both good and bad. CIFAR is intended to be completely comprehensive. So if you want to be sure you have everything there, that's probably what you want to do. Often it's impossible. If you want to be a bit more pragmatic, then I would say you might think about PRISM or another model. There are others there. This is another web tool, transparency. We're very involved with this also, but we don't make any money off of it. It's available to the public, and it takes you through the stages of selecting one that might work the best for you, or as you can see, a combination. It starts with, I noticed Debbie's head anyway was nodding when I talked about logic models for a little bit. It has you start by constructing your own logic model in a fillable PDF, and then using that, the key constructs, to select a set. It will return which theories seem to match the best for that. Most important are going down across that is that you use it after you get your theory or whatever set, is that you use it throughout. You don't just talk about it in the introduction to your proposal of paper, but you use it, you assess it. And the latest thing we're working a lot on right now is providing we're trying to increase the number of tools. I think we have 73 assessment tools and what they're linked to and kind of their key characteristics.
I just wanted to add very briefly, if you are combining, make sure you provide a rationale. Why do you need to combine them? And how are they working together? Sometimes I've seen, we're using these two or these three, and that's it. So they really need to, I need to know why you decided to combine them and how are you combining them that there is cohesive. So just keep that in mind for project reports or grant proposals.
Yeah, and I really love that you called out logic models, because logic modeling is something we have started doing with all projects that we start. And I do want to emphasize that they are very helpful for getting a bunch of stakeholders on the same page. Yeah. So I'd like to emphasize that. I was clapping along with that. One of the things our center does, we're obviously the Center for Digital Transformation of Health, and I was wondering if you could speak to how you might use PRISM with digital health interventions. It seems I started in the health promotion field in 2011, and I remember at the time it was like mobile apps are the next thing in health promotion. And now we're in this phase of where it's AI everything. So I was just wondering, given just how much things have changed, where you see maybe using PRISM within a digital health intervention, or just thoughts on that.
Yeah, great thought. Again, that would be a really fun, much ongoing discussion. I have a couple thoughts, but Monica, do you wanna start, or do you want me to with that one?
No, we have a very few minutes, so please go ahead, Russ.
Um, I'll just say we have a couple examples how it's been used that we can send you in papers, but I think the first thing I would say is because of exactly what you talked about, Debbie, is what we call the forms, or the particular, what's the device you're using changes so rapidly. And time you get a grant and study it, it's out of date and we're on to something else. But the function usually that you have, I think, focusing on that. I definitely think we've learned a lot, and we need to learn a whole lot more about user-centered design, the human factors approach, and things like that. I think those fit really well. By the way, some conceptual models there I think might fit very well with PRISM, to think about that. But I think key there is really iteration, 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 and making sure that from a PRISM, where you think about that cascade we showed you, that we're getting everybody at the table there that's testing it, because of the huge differences, particularly with the digital divide and issues like that. We look a lot with rural areas and things like that. So that was a quick, I'm sure, really incomplete, not real well thought out answer. But Monica, do you want to add a couple other thoughts?
Just to add that, I think, Debbie, that's a paper we're thinking about and working, and we're very interested. I am passionate about, what about fidelity? How do we measure fidelity with a digital intervention where implementers are different? And sometimes your end users are interacting with the tool on their own. So all of these are good questions that we need to flesh out more in all fields: health promotion, implementation science, and contribute to this area that is rapidly changing.
Yeah, I completely agree. I'll follow up with you. We only have a minute left, so I think we probably need to wrap it up here. There are some questions that are unanswered, but I will save those, and perhaps we could answer those offline, because there's a lot of really good questions here, and just speaks to the audience. Before everyone goes, if you could scan this QR code and let us, you can see other events that we're putting on, and we have our email there as well on our website. So with that, can we just give everyone a round of applause? I guess I don't know how this works with Zoom. It's a little bit harder not being in person. If we were there in person, we'd probably be cheering and giving you a standing ovation.
Thank you. Oh, we appreciate, you're all very kind. I can see the clapping and some confetti thing.
All right. Thank you so much, everyone. And we will end here.